Lisa?
Ardesa with an
Good
S, Ardesa.
good afternoon, and welcome back to the next talk. All right. So we will be talking about the impact of trauma on the Latinx community. Thank you so much for being here this afternoon and this morning. It has been a very fruitful conversation, and I know that this conversation will be no less. And so we have with us Dr. Con- Condesesa, received her MD and her PhD in medical anthropology from Yale University, where she began using scholarship and activism as tools for health justice. She coined the term race conscious medicine to emphasize how racism, rather than race, determines illness and health. She is currently completing her family medicine residency and will continue working in the intersection of research, community oriented primary care, and healthy policy. We also have, oh, I'm sorry, I'm confused. That was Dr. Cardenina. Sorry, I apologize for that.
Thank you.
Cardania, my apologies. This Dr. Cardessa was born and raised in Argentina. She spearheads trauma-informed and resilience-centered programs as Esperanza, a leading Latino organization based in Philadelphia. Prior to her joining Esperanza in August 2023, Dr. Cardessa worked at the Center for Victims of Torture as a member of its Rapid Response Management team and has been adjunct professor at Esperanza College since August 2022. Welcome and thank you. I will now turn it over to Dr. Let me see who's going first. Dr. Kenyanya.
Thank you. Give me just one moment as I pull up my slides. All right, are you all seeing my slides?
Yes. Yes.
Perfect. So thank you so much for that introduction, and thank you so much for being here and for the invitation to speak on this topic. This is something that is challenging to talk about, but also provides a lot of opportunities to think about how structural factors can be addressed and overcome in terms of thinking about the futures and ability for everyone to achieve their full potential. So what I'd like to talk about is a little bit about how I first got into this topic without delving too far into my own personal history, thinking about my own research and background with respect to studying intergenerational trauma in the Latinx population, and to share with you some of the findings that are the basis of my book, Pressing Onward, The Imperative Resilience of Latina Migrant Mothers. So, as mentioned before, I have the dual role of being both a researcher and a clinician. And as you can probably tell from my scrubs, I'm actually occupying a different space, also caring for mothers and babies here on our maternal child health unit. But, you know, rewinding back to medical school, I worked as a Spanish medical interpreter and behavioral health psychoeducator for a clinic, a student-run free clinic that served predominantly undocumented migrants. And that was called Haven, La Clínica Gratuita. And one of my patients, Eulalia, I'll call her, was 57, separated with one daughter. She was originally from Mexico. She had been living in the States for the past 20 years, first in Long Island and then in New Haven. And she was referred for psychoeducation, the program that I was a part of, after screening positive for depression at her medical visit, where her providers were treating her for a whole host of other somatic concerns, including back and knee pain, headaches, bladder prolapse. And her initial screening, which we use a tool called the PHQ-9, was 17, which was suggesting moderately severe depression. And so I was working with her along with colleagues to help her understand and manage her stress, particularly as it related to her experience as a migrant mother. And I remember sitting in the session and kind of going over my notes from that time, and thinking about the factors that Eulalia had going on in her life. So she had migrated with her ex-husband in search of work opportunities. She had challenges in that marriage. Her husband was not faithful and manipulative, and she ultimately separated from him. She remarried to a US citizen, but that power dynamic of him having citizenship and her being undocumented created an imbalance, such that he became abusive. He controlled her finances and became physically violent with her. And Eulalia's daughter witnessed that. Eulalia sought advice in her local parish, and a priest told her that she needed to protect her daughter and seek a fresh start. And Eulalia noticed that there were changes in her daughter, especially as she reached adolescence, that she was more withdrawn, she was failing out of school, and at one point, in the most extreme moment, she attempted suicide with a medication overdose. And the daughter had decided that she was going to live with a father, and that was really challenging for Eulalia at the moment. And Eulalia really felt and latched onto this idea that the trauma that she had experienced personally, the trauma that her daughter had witnessed, really precipitated all of these developments in her daughter's life course. And so as I was thinking about all of these things, I remember meeting with Eulalia. She was about 40 minutes late for our scheduled appointment, but she was smiling. She had this smooth black hair with some rebellious grays springing from her temples. And as we took a seat, she interrupted me before I could get into any of the material. And she told me, my daughter is everything to me. She and I only have each other, but she wants to leave to go back to live with her father in Long Island. She thinks things will be better there. I'm so afraid for her. And then I saw these hot tears streaming down her face and her face getting redder. She tried to kill herself, she stammered. She took all the pills out of the medicine cabinet and tried to take them. I found her when she was starting on the second bottle. We took her to the hospital, but we told them it was an accident, that she'd misread the label, and praise God, she was okay. But I'm so afraid for her. I think this is all my fault. That story and Eulalia's narrative that she had constructed for making sense of those events pierced me, and it really shaped the way that I approached future psychoeducation sessions with migrant patients, and also sparked some of these questions about the impact of trauma across generations. And as I learned more about the kinds of, from my patients themselves, what they shared with me about their experiences in immigration detention, financial stress, child sexual abuse, intimate partner violence, many of these women particularly felt that their children's emotional or psychological conditions, or the way that they related to their mothers, resulted in part from the wounds that they had themselves sustained. And that kind of brought me to think about putting on my research hat, what does this mean? Thinking about intergenerational trauma. And at that time, I was considering how are the multifactorial processes by which this trauma can be passed along through generations. And the work by Dr. Rachel Yehuda, a professor of psychiatry and neuroscience at Mount Sinai, had started kind of building her literature about the associations of DNA methylation, which is a form of epigenetic modification at a gene involved in the stress response among parents who had been exposed to the Holocaust prior to having children, and then the children themselves. And there was, in this 2016 paper, a weak demonstration of biological embedding of parental trauma in the epigenomes of their offspring. So this kind of prompted me to think about what could be going on in the migrant population that I was working with, and how were these concerns that mothers were raising about their children, the traumas that they experienced, the impact on their children, what mechanisms could be underpinning these findings. And I was curious, how do mothers' narratives of trauma correspond to epigenetic signals? Are there modifications at stress-related genes? Um, are there more kind of behavioral mechanisms? And I sought to answer these questions with my own work. Now, no research exists in a silo, and as I was kind of thinking about this topic, I worked with a lot of my peers. I've been very grateful to be part of the Robert Wood Johnson Health Policy Research Scholars Program, and many of us kind of coming from backgrounds underrepresented in the academy, we were able to kind of give each other feedback and think through, what this kind of work, what our work means and what are the implications of it, particularly for policy. And as I was sharing these kinds of thoughts about these questions with my Black and Latinx peers, many shared their hesitations, making comments like, "We're not broken," or "Don't you think that white supremacists would have a field day with some of this research?" And those exchanges left me really struck, thinking about, I had this idea that, the research on biological embedding could challenge neoliberal and medicalized impulses to blame women like Eulalia for poor parenting, rather than considering how experiences of structural vulnerability might shape neuroendocrine programming, predisposing oppressed families to psychopathology. But this work could also be weaponized in ways that reinforce social inequality. And this was something that really changed the direction of my work, and prompted me to ask really critical questions about how I was going to go about answering this. So I asked myself, what would it mean to someone like Eulalia if kind of conducting these biomarker studies were null? And I asked, what did I need to prove? Would it be adequate to understand from Eulalia's narrative and what she understands of the impacts of her trauma on her daughter? Could that tell me everything? And I ultimately concluded, yes, the answer was yes. And so just to kind of provide a little bit of context for how to conceptualize intergenerational trauma in the Latinx community, a lot of the predominant literature on studying trauma and intergenerational cycles of trauma in our population centers on cycles of violence, normalization of harmful, entrenched behaviors, including harsh parenting that have propagated across generations. And this comes from a scoping review that I conducted with a colleague. But a lot of this literature was considering how, certain social norms around gender and culture contribute to this dynamic. And yet less was considering how structural violence and the attendant vulnerabilities of Latinx people to oppressive structures serve as precipitators of intergenerational trauma. And beyond that, beyond intergenerational trauma, thinking about transgenerational and historical traumas, colonization, genocide, mass political violence, or even the role of migration itself as a traumatic event. And in my own scholarship, I sought to attend more deeply to the impact of these structural factors, including migration, on the experience of trauma for women and their children. So this research is based on ethnographic interviews that I conducted with 65 women, in largely in 2020 and 2021. So in the height of what many were experiencing as the economic and social and health fallout of the COVID-19 pandemic, a lot of my interviews were rounded out by additional work with community leaders and clinic staff. And this is just some of the demographic data of the women who I interviewed, who in the greater New Haven area, we have large representation of migrants from Mexico, Guatemala, Ecuador, and to a lesser extent, Puerto Rico. And there was wide variation and representation across many countries, including length of stay in the United States and age. And all of these women I interviewed during pregnancy, and I want to share with you some of my findings and some of the key details that I feel like deserve to be highlighted and brought to the forefront when considering the impact of trauma in this population. So I'll share with you this narrative. Miss, I'm very sorry. Lydia halted, her voice lacking the easy confidence of our earlier conversation. I'm worried that my details could be exposed, and the truth is very concerning, above all for the safety of my family. I reassured Lydia that her information would remain confidential and that she was welcome to share no more than she felt comfortable doing. In Honduras, my husband was a doctor. He worked for the Ministry of Health and for the Attorney General's office. He was the coroner in the area where we lived. Lydia began tentatively. What happened is that about a year ago, my husband began receiving anonymous letters at the door. After a couple months, my husband moved us to a town 20 or 30 minutes away, saying that it was so I could be closer to work. But they were only there about a month when he tells me, look, my assignment has been changed and we need to move to the city. The city was now about 6 or 7 hours away. And I asked myself, how could it be that we just unpacked the last box from our move a few days ago and now we have to move again? My husband said again that it was due to his job. So we moved and we found a new school for my son. After about 4 or 5 months, I noticed my husband acting more strangely. He never said anything to me, but I could tell, and I would ask him about it, but he would never say anything. Until one morning, before going to work, he woke me up and said, look, I need to talk to you. That morning, he had found my car with the entire passenger side beaten in, and he had found a note that said, as much as you want to hide, we know where you are, and we know where your wife and son are. The police said they were going to protect us, but it never happened. No one was outside the house. No one knocked on our door to say, we're here in case of any suspicious activity. I mean, nothing, nothing, nothing. We had a tourist visa for the US that we'd received 3 years prior by the grace of God. We had no choice but to leave. We took one suitcase each. I didn't even say goodbye to my parents. Lydia and her family stayed with a relative for a few months while they settled in New Haven. Her husband took a job in landscaping to support them. In Honduras, my husband was a professional, a doctor. And now what does he do? He had to learn to use tools. The changes in his body, in his face, in his hands have been... Lydia's voice trailed off. He comes home and plays with my son, and my son says, Daddy, your hands hurt me. And my husband says, well, yes, look, my hands are hurt. And my son tells him, yes, but don't touch me with your hands, you're hurting me. Lydia's family had applied for political asylum, but according to their lawyer, their case was complicated because they had overstayed their tourist visas. And because of the COVID-19 pandemic, their case had not yet been processed when we spoke. We move around with the greatest caution, Lydia said, because we're already here. Ilegal, you know? Latin American history is pierced by violence. From colonization, African enslavement, and indigenous genocide in the 15th and 18th centuries to political conflicts and brutal dictatorships amid state modernization in the 19th and 20th centuries, and social strife arising from state destabilization in the contemporary period, each era of Latin American history features acts of inhumanity perpetrated by dominant social and political groups against subordinate ones. While this history of violence affects individuals and communities through historic and transgenerational trauma, it is current sociopolitical upheaval, including assaults and homicides, as well as weak social safety nets, that most directly informs decisions to migrate. This new violence reflects social disruption and the ways gestures toward democratization have failed to meet the needs of citizens. Lydia detailed the pain of thrusting her 4-year-old son into a strange country. It's so stressful for him to speak English. He asks me, but Mommy, why can't I speak English? And to everyone on the street or at Walmart or at the grocery store or the laundromat, he asks, do you speak Spanish? Do you speak Spanish? He wants to play and interact with others, but he can't. It's so difficult. This decision to migrate is fraught with danger, destabilization, and isolation, and yet the advantages to life in the United States often outweigh the struggles of migration and resettlement. In short, state failure not only drives transnational migration, but it also sustains it. A state's inability or deliberate failure, in some cases, to provide adequate protection and assistance, as well as full citizenship rights to all, undermines peace and stability. The production and maintenance of an underclass in Latin America, stripped of civic entitlements, spawns a new underclass of illegals in the United States who serve as a cheap and exploitable labor force. But that process of migration itself inflicts its own harms, which I'll illustrate through the narrative of Caridad. We were 3 or 4 women and 13 men in the group, Caridad, a 34-year-old from Peru, told me. If we had to run, we women knew we'd be left behind. Caridad spent 3 months traveling from Peru to the Mexican border. She had to pay off multiple soldiers and border guards to arrive safely. They gave us a backpack with water, some fruit, and some canned food. The water was so heavy, I didn't want to carry it. The canned food was awful. It weighed so much and it didn't give much energy. It made me sick. 2 of the women became very ill, vomiting everything they took in, and they had to turn back. On the second or third day, I couldn't carry it all anymore, and I almost left everything behind. Another Peruvian man in the group helped me carry my gallon of water, but despite all that, I became very dizzy. The man took out some oranges and pressed them to my lips. He told me I needed to go to the river to drink some water. I couldn't walk, so he carried me on his shoulders and brought me water from the river. We had to hide in the holes in the ground from the immigration planes overhead. When Border Patrol found us, the man and I managed to hide in some bushes, but they caught the other woman, the niece of the other traveler, and sent her back to Mexico. The uncle crossed back to find her and try again, and it was just 12 men and me. I tried to lead. I thought, if they start running, where will that leave me? After several more weeks of travel, Caridad arrived in New Haven. It's safer here. In Peru, they'll shut the lights out on the bus and steal the necklace right off your neck. It happened to me, gave me a huge red mark, Caridad explained. Here in New Haven, you can carry your purse to the store without worry. Plus, in the summer, it smells like the ocean. Caridad's story attests to the physical toll of migrating across the desert. She endured dehydration, exposure, and the precarity of being a woman in groups of mostly men. Caridad was lucky. She arrived at her destination safely without encountering migration authorities that forced her back. Less fortunate migrants may make multiple attempts to cross after environmental hazards and immigration authorities redirect them. Latin American migrants face dangers such as thievery, kidnapping, extortion, and dehydration. Women are also at greater risk of rape, assault, trafficking, and forced prostitution. After settling in the United States, many of these women experience intimate partner violence as their social positions make them vulnerable to abuse. Over 75% of Latin American migrant women living in the United States report histories of trauma. Scholars Pereira and Ornelas refer to harrowing migration experiences as painful passages. In their study of 281 individuals, they found that 29% of foreign-born adolescents and 34% of foreign-born parents living in the United States had experienced trauma during the process of migration itself. Of those with traumatic histories, 9% of adolescents and 21% of their parents were at risk for post-traumatic stress disorder, or PTSD. Coinciding global and local sociopolitical forces, including economic factors, government structures, and legal violence that shape migration experiences, also affect health outcomes. So how do we make sense of this trauma? Trauma often involves a close encounter with physical violence or death, but trauma encompasses more than that. It also is the emotional response to that experience, the psychic scars left by tragic and painful events. Trauma is therefore a clinical and social event in which individuals' subjective memories of trauma shape or rupture their sense of coherence in their lives and may lead to symptoms of mental illness or not. Migrants, including voluntary migrants as well as refugees and asylum seekers, are especially susceptible to trauma and its aftermath. Migration-related trauma, a term referring to trauma surrounding departure or displacement from a country of origin and relocation into a destination country, applies to the experiences of many of my interlocutors. Here I examine the specific traumas that migrants encounter, specifically the effects of legal violence, of immigration enforcement, and the gender-based violence as factors in health outcomes. When I crossed the border, immigration authorities caught me. 19-year-old Isabel recounts. I'd arrived in Arizona, but they took me to Texas. I was there for a whole week. Being in jail was horrible. There were no windows, no way to look inside. If it was night or day, I didn't know. And the food was terrible. They told me it was called La Hielera, the ice box, the place where they locked me up. It was freezing. They gave us these aluminum blankets, which helped a bit, but not much. It was so cold. I got a bad nosebleed. A lot of blood came out and I couldn't get it to stop. They just gave me some ice and some kind of pill to make me stop bleeding. There were like 30 or 40 of us locked in the cell. I didn't count. The bathroom was disgusting, open in the cell and covered by just a few bricks. It smelled awful. I had no freedom to move about. I was locked in there the whole time. Some of the guards would intentionally wake us up when we were sleeping, banging on the doors. Some just walked around the cell to try to catch us doing something. Almudena was detained by immigration authorities 5 times. On each occasion, she was booked, strip searched, and deposited at the border. They would grab us, put handcuffs on our wrists, and ask us to remove our shoelaces, belts, and anything we carried. We had to let our hair down. If we wore rings or earrings, we also had to remove them. They separated the women from the men. They arrested so many of us. From there, we had to wait until it was our turn to give them information. They took photos of us and fingerprinted us, and then they would just take us back to our cell until they let us leave. They would grab like 15 people at once and then just dump us at the border, leaving us. Ascension recounted her imprisonment with her 2 children. It was like a refrigerator, a hielera. The room felt very cold. They would wake you up and undress you. You couldn't even lie down. It was so crowded. I conducted my fieldwork at a time when the system and conduct of immigration authorities came under intensive scrutiny. In the spring of 2018, the zero tolerance policy against irregular migration imposed by the Trump administration cruelly separated thousands of migrant children from their parents, hundreds of whom had yet to be reunited. A number of congressional representatives publicized evocative photos of detention conditions, including images of unbathed children on cots with tinfoil blankets, surrounded by chain link cages. This form of judicial punishment lays hold on the soul. Isabel experienced the physical discomfort of crowded conditions, rationing of food, freezing temperatures, and sleep deprivation. But incarceration also has a cumulative dehumanizing effect. Constant surveillance and the targeting of migrant bodies for disciplinary control grooms them for subservience, docility, and compliance as members of the American underclass. Migrant bodies serve as locales of regulation, emphasizing the role of the state in defining legitimacy. The Salvadoran sociologists Cecilia Menjivar and Lacey Abrego proposed the category of legal violence to describe the punitive and disciplinary functions of the law and the way it harms migrant bodies. They argue that immigration policies purposely construct the status of illegality. And US immigration policy has historically engaged racist exclusionary practices that welcome migrants as cheap sources of labor while withholding state protection from them. The 1790 Naturalization Act required each naturalized citizen of the United States to be a free white person of good moral character. And this orientation persisted with the Chinese Exclusion Act of 1882, which banned Chinese nationals from immigrating or claiming US citizenship, and the 1921 Emergency Quota Act, which set quotas for immigration from countries outside the Western Hemisphere. By contrast, the Immigration Act of 1864 and the Mexican Farm Labor Agreement of 1942, which is often known as the Bracero Agreement, provided for migrant labor to address US worker shortages on farms and factories. US political leaders have continued to enact laws to allow US employers to access and exploit migrant workers while blocking pathways to full citizenship. In this way, immigration enforcement epitomizes racial capitalism. The subjugation of brown migrant bodies advances neoliberal interests. The Canadian activist and scholar Harsha Walia writes, US border rule reveals seamless relations between the carceral administration of genocide and slavery at home and imperial counterinsurgency abroad, domestic neoliberal policies of welfare retrenchment, and foreign policies of capitalist trade and local and global regimes of race. US policy has carefully configured the category of illegality as a sociopolitical condition characterized by an unequal power relationship to the state. Unlike citizens and permanent residents, undocumented migrants cannot make claims to political or legal security, which compounds their social vulnerability. Sociologist Nicholas P. de Genova says, if there were no borders, there would be no migration, just mobility. Moving from one's home country to the United States involves separation from familiar social groups and structures and transition and incorporation into the new society. And for many migrants, that latter process of incorporation remains incomplete. They are folded into the nation without becoming part of it and remain excluded and objectified. I now want to turn my attention to gender-based violence, a particular concern for migrant women. One of the guides was a man who was about 50 years old, Jacqueline told me. He told me that I should stay and live with him, that he was going to give me everything. that he already had a wife, but he wanted to pay me to be his mujer, or his woman. I said no, that I had no intention of doing that. He pushed me to have sex with him. He told me, if you don't accept, I'm going to leave you out in the dirt. And he said, you have no one. You have no one here. And now you're in another country, so you can't do anything. I was afraid inside, but I told him that he had no right to harm me. And he just laughed and said, oh, yeah? How can you prove it? Who do you think is going to look out for you? And I answered, my family that I have there in the United States. And so he said, what can your family do? Your family is there and you are here. You are in my hands. After that, he started treating me badly. He no longer paid attention to me. He would leave me behind and wouldn't wait for me. At one point when we were walking, a very big thorn, like as big as a nail or a screw, got in my shoe and cut off my foot. But the man was already so upset with me that he refused to wait with me. I was scared that he would leave me lost in the desert. I did get lost once. The guide, he left me and two others behind, so we spent the night alone. I don't know if you've heard of those animals. They're like big dogs. We call them the coyotes. They're huge and they eat people. We slept under the trees and we could hear the coyotes coming closer, shrieking and howling. We had no idea whether or not we would live. It was terrifying. Although that guide never directly assaulted Jacqueline, his threats, intimidation, and neglect after she rejected his advances rendered her journey far more precarious. Fear of rape was among the most common concerns for women who crossed the border. In my interviews, I heard many variations of the same dread. There were those rumors that they touched women, but you take a risk if you want a better life, the life you want to lead. It was ugly, traveling as a woman. The men are very macho. I was afraid of rape. I thought our coyote would grab us when he was high on marijuana because there were two of us women. I was so afraid he would rape me. Although none of the women with whom I spoke reported being sexually assaulted during their crossings, their narratives may omit such experiences as a result of feeling shame and denial. Many, like Jacqueline, were harassed, intimidated, and threatened with abandonment. And those fears are not unfounded. Up to 90% of women migrants suffer sexual violence. Likewise, threats of leaving women behind to cope alone in the deserts has a ghastly basis in fact. In their study of bodies recovered along the migrant trail, the Binational Migration Institute found that women had 2.87 times greater odds of dying of exposure relative to men. This particular plight of women migrants often receives less attention in scholarly work on migration because most individuals apprehended at the border are single men. Women's choices to migrate, intentionally facing the risks of rape and abandonment, highlight their agency. All my interlocutors recognized the risks. They undertook careful evaluations of their past and their possible futures in their decision to engage in the violent process of migration. So how should we understand the role of threatened violence and this gender differential in risk? Gender-based violence is often invisible. Even penetrative sexual assault rarely leaves marks on the body. Despite the absence of visible scars, such violence persists into the futures of those who experience it. The anthropologist Carolyn Nordstrom notes that these forms of violence have a tomorrow, leaving behind shattered selves, confidences, futures. The most common trauma symptom reported by my interlocutors was the harboring of strong negative beliefs about the world, such as no one can be trusted and the world is completely dangerous. These enduring attitudes shape the ways women relate to others and to their new environment. The nature of these symptoms underscores the limitations of clinical instruments for assessing trauma. And I say this as a clinician myself. So the tool I use, the PTSD checklist for the DSM-5 or PCL-5, asked about the experience of sexual violence and threats of sexual violence separately, allowing me to account for the common experience of the fear of potential assault. My index of trauma symptoms did not fully capture the warlike mistrust and lingering fear that many of my interlocutors carried. After fearing sexual assault at the hands of her boyeros or smugglers, confronting theft, and enduring 2 months in immigration detention, Almudena described to me a psychological state akin to shell shock. Some of these things hurt too much. You can never fully recover, Almudena said. When I first got here, it was different, difficult. Why couldn't I just lead a happy life? I was filled with negativity. Everything bothered me. She paused before continuing. From there, you decide to pull away from people. I stopped talking with my cousins and my friends at work. It's like no one can understand what happened. Such patterns of avoidance and mood change are characteristic of PTSD, yet Almudena's score on the PCL-5 was just a 2 out of a possible 80. And in that way, the instrument didn't record her psychological sensitivity in the way that deep ethnographic engagement did. And after my interview with Almudena, we spoke about the services that would benefit her, as well as the power of being heard. Humanity needs to hear these stories, right? About us immigrant women? Her tone became urgent. People do not know. It is honestly incredible that it's happening in humanity. Why build the walls, right? Or the borders? Without these barriers, so many people would not expose their lives because so many people have died right there in the desert. Why not give us a permit so you can just let us in to work? And at this juncture, I want to highlight the particular role that I occupied and that many of us occupy when engaging in topics of trauma with people who have experienced it. Almudena said that I was the first person she had told about her experiences of near rape. The vulnerability and intimacy surrounding gender-based violence and the fear of not being believed fosters isolation, as Almudena acknowledged. And as I heard these stories, my ethnographic engagement often took a form of care work, tuning my attention to the intimate needs of my interlocutors. And this is something that feminist anthropologists have commented on for decades, particularly among women survivors of sexual violence. Ethnographic research requires dedication to and solidarity with communities. And in consequence, anthropologists often engage in translational aid, using their social capital as well-connected academics to persuade those empowered to understand and act on the needs of their interlocutors. And for me, at the time, as a medical student and ethnographer trained in psychoeducation and mental health first aid, as well as a Spanish speaker, I often found myself being the first person providing the psychological support and helping connect women with clinical resources. When mental health concerns exceeded my capacity, I connected women with mental health support. And when they confronted their own forms of economic and social deprivation, or when their isolation prevented them from fulfilling their needs, I found myself in the role of facilitating social services like mutual aid, nutritional support, in some cases, hand delivering boxes of donated food to women experiencing intense social and economic stress. And with all of that, I often found myself in awe of women who, despite immense economic adversity, limited social support, seemed astonishingly okay despite such harrowing traumatic histories. As a mother who myself found raising a young child challenging, even with dual income partnership and family support with childcare, I was so humbled by the mental fortitude of the women I interviewed and what they were demonstrating to me. And comparing my situation with theirs prompted me to reflect on conventional understandings of resilience. So definitions vary, but resilience generally refers to engaging resources in the face of adversity to achieve goals. Unlike concepts of positive psychology and competence, resilience considers social environment as a factor influencing an individual's ability to adapt to difficult life circumstances. Resilience and its companion concept flourishing emphasize healthy functioning, or at least an absence of psychopathology. These terms often imply well-being and positive or protective factors, which can be measured using pre- and post-intervention assessments and behavioral health research. And nearly all scholars of resilience in clinical medicine, public health, and related social sciences agree that resilience should be optimized and seek to pinpoint the ways that it can be cultivated. This interpretation of resilience fixes the concept as a static characteristic akin to toughness or grit, rather than as a process of rational action. A more nuanced conceptualization of resilience views it as a trajectory or a process of adaptation or sustained healthy adjustment over time. Interpretations of trauma and marginalization that recognize individual identity and agency within social, political, and cultural circumstances allow consideration of mental health responses that are not uniformly negative. Now, as I was conducting this research, I worked with assistants, many of whom identify themselves as Latinx. And when I brought up with my community the topic of resilience, many of my assistants cringed. One said, at La Casa, which is La Casa Cultural, the Latinx Cultural Center at Yale, we talk a lot about resilience, like it's something white people think we should have for making it here. One of my students commented. But that's not it at all. I mean, we're resilient because we have to be. And then the joke became that the response to, wow, you're so resilient, should be thanks. It was between that and dropping out or dying. Theories of resilience tend not to conceptualize it as a mode of resistance to oppression, but my interlocutors reveal that this is exactly the dynamic at play. Resilience is not an ability or a choice. It is a conditioned response to the multiple forms of violence they encounter through racism, sexism, and immigration enforcement, as well as economic inequality. In recognition of this reality, I propose the term imperative resilience to describe the strategies women employ cognitively, emotionally, and socially to get by in the face of overlapping adversities. Priscilla, for example, told me that she could not afford to let her emotional responses interfere with her ability to handle stress. Instead, she focuses on problem solving. Let's say I do not have something that I should, she explained. For example, this month, I only had half the money I needed to pay the electric bill. I could make the bill that month, and so next month I'm going to have to work more hours to cover it. If I get angry about it, things will just get worse. I won't solve anything. So I just try to calm down and look for solutions to be more economical and more organized. Priscilla seemed almost puzzled by my questions about how she bounces back from stress or other difficulties in life. I try to keep things simple, she responded. If I complicate things, I'm not going to solve anything at all. If I complicate things, I get home in a bad mood and I take it out on my children. But they are my responsibility. I have to be the responsible one. If I get angry and yell and scream to let off steam, it solves nothing in the end. Quite the opposite. It makes things worse. I just have to calm down and look for solutions. I have to accept and endure. These themes of acceptance and endurance and the desire to shield children from stress echoed throughout my interviews. Women felt it was their responsibility to minimize their affective responses to difficult circumstances to preserve the emotional and physical health of their children and their pregnancies. And in this way, it challenges the conventional notion in a lot of the literature regarding intergenerational trauma and Latinx folks regarding parenting behaviors as being the primary driver. These women demonstrated that they were doing everything possible to try to shield their children and to mitigate the impact of their trauma on their behavior and their interactions with their and attachment with their children. So at first glance, Priscilla's coping strategy might be viewed as maladaptive. She could say that she's emotionally numbing, intellectualizing, repressing, some cognitive avoidance, which can be associated with worse health outcomes, greater stress and depression. But these women also employ positive coping strategies. Priscilla demonstrated her problem solving, benefit finding, altruism, personal and spiritual growth. Priscilla might suppress her emotional reactions to stress, but she does so out of concerns for her children. She focuses on practical solutions to her challenges, like adjusting her work hours and her budget. And these strategies for survival are what I characterize as imperative resilience. It's a performance that becomes actualized through practice. That necessity of suppressing negative emotions, emphasizing the positive, and strategic problem solving reflects not an inherent grit or toughness, nor special access to social material resources. Rather, it arises as a form of opposition to social injustice, a way of summoning personal and social capacity to fill the voids left by society. And now it's important to talk about another potentially mass traumatic event and what it means for the social vulnerability of migrant communities. So the COVID-19 pandemic exposed many of the deep fractures in our social safety net. Women like those I interviewed were particularly vulnerable to the effects of the pandemic. Many who held low-wage essential jobs were unable to work from home and were at risk of exposure to the virus in the workplace. Several lost their jobs, but were barred from collecting unemployment relief or the stimulus payments offered through the Coronavirus Aid, Relief, and Economic Security, or the CARES Act. As a result, they were compelled to engage in precarious work arrangements. Many lacked the financial resources to stock up on food and household supplies, requiring more frequent trips to stores, which also increased the risk of exposure. And many, given lack of healthcare access, undocumented migrants had been less likely to receive prompt evaluation for symptoms of COVID-19. And although testing for COVID-19 was often free, evaluation and treatment were not. And those costs often deterred low-income undocumented migrants from seeking the necessary care and increased their risk of mortality, which we know there was a disproportionate burden of COVID-19 related morbidity and mortality among Black and Latinx populations, particularly early on. And I'll demonstrate this with the story of Antoinetta. I used to work at Amazon, scanning products, says Antoinetta, a 23-year-old from the Dominican Republic. I liked the work, but it was so long, 11 or 12 hours at the time. But I had to quit my job when I caught the coronavirus there. I got it there and I haven't gone back. I'm too afraid. Especially now that I'm pregnant, I worry something that'll happen to me again. Antoinetta contracted COVID-19 in May 2020 at an Amazon distribution warehouse in North Haven, Connecticut. Just 1 month later, allegations of the company's disregard for employee safety exploded throughout the news media. Warehouse workers criticized Amazon for failure to implement physical distancing protocols, noting that the wearable devices used to signal proximity of less than 6 feet to other employees were useless because it was impossible for workers to keep 6 feet apart. Some employees showed up to work despite COVID-19 concerns or symptoms out of fear of losing their jobs, and many stated that they did not receive enough time to properly wash their hands and disinfect workstations, and attested to delays or non-payment of compensation for quarantine or isolation following exposure or confirmed infection. It was like a week, no, 2 weeks, I should say. My whole body ached. I couldn't even get out of bed. I had no sense of taste, no sense of smell. I couldn't eat much. Sometimes I felt like I couldn't breathe. I never went to the hospital. I only went to get tested. I was scared. I just went out to get tested and went home. If it got really bad, they said I could go to the emergency room or I could call and they would send an ambulance for me, but I was really scared. Antoinetta's fears were twofold. First, she feared that if she had to be admitted to the hospital, her condition would worsen. She had a cousin in the Dominican Republic, just 40 years old, who had died in the hospital that had exceeded its capacity. They did what they could, she told me. But everything had collapsed because so many people had the coronavirus, and my cousin just died. Antoinetta feared a similar fate. Second, she worried that the hospitalization would incur insurmountable debt. Although she had recently obtained medical coverage through Husky, Connecticut's state version of Medicaid, after acquiring U.S. residency through her citizen husband, Antoinetta had been scarred by the costs of treatment when dizzy spells from dehydration and overwork at Amazon had landed her in the emergency room. I got a big bill, she tells me. It's still there. I have to agree to pay it little by little. It just added up. All of these experiences point to policies, necessary policy reforms to overall improve the experiences of migrant communities. First, we need universal health care that includes adequate behavioral and mental health services. In Connecticut, recent legislation expanded Husky to children up to age 15, and a proposed bill would extend that up to age 26. However, during the current legislative session, they are only considering an extension up to age 18, but that would leave many uninsured. We can do better. Second, we need provisions for basic needs like food, housing, and diapers, whether through a form of universal basic income or the expansion of services like SNAP and TANF to non-citizens. Third, we need a clear and accessible pathway to lawful migration. Updating the migration registry, which has not been previously touched in 40 years and has previously received bipartisan support, would adjust the status of an estimated 8 million undocumented residents, acknowledging their presence and contributions to American society and rewarding that with legal protections. I share this metaphor because it was one that spoke to me, understanding the migrant experiences and the sacrifices that parents make. So join me as I share this with you. Monarch butterflies, with just a 3 to 4 inch wingspan, travel 50 to 100 miles a day during their migration, flapping their wings 5 to 12 times per second. As the days shorten and the temperatures drop in their breeding areas across the United States and Canada, their primary source of food, milkweed, disappears. The butterflies overwinter in the mountains of central Mexico, shielded by oyamel fir trees, whose microclimate protects them from extreme temperatures. As the days lengthen and the temperatures rise, this climate becomes inhospitable, prompting them to leave their roosting sites. Mated female monarchs leave first, blazing a trail that the next 3 to 4 generations will follow. These long and exhausting migrations are essential to the breeding success of monarchs. Their resilience, like that of many of my interlocutors, is a necessity, a means of survival in a harsh and ever-changing world. I understand the resilience of these Latin American migrant women as resistance to structural violence. Instead of ascribing this resilience to the social environment, I consider it a form of psychosocial rebellion against oppressive structures. Women summon religious beliefs, self-conceptions of strength, and altruistic concerns for their families to fight against social and economic subjugation and to seguir adelante, or press onward. And I hope to be able to share this with you. Just want to make sure that my sound will work. When the weather turns and the milkweed wilts, monarch butterflies lift their wings and embark on a perilous migration from the United States to Mexico in search of nectar. In the face of deforestation and climate change, they journey for their survival and for the survival of their offspring. Theirs could be a story of suffering, but I see it as one of power and persistence. Like the monarchs, mothers who migrate from Latin America to the United States face extreme obstacles. They craft their futures and the futures of their children despite devastating inequality, harmful politics, and a global pandemic. They too can be seen as sufferers. Instead, I see resistance. I call this imperative resilience, a strategic approach to push onward, or seguir adelante. Imperative resilience sounds like Adelina telling me, whenever something seems stressful, I just don't think about it. I'm just like, there's going to be another day when you can make it better. Or Elvira explaining, you just have to accept it and adapt. Create something nice out of it so you don't have to focus on the bad. It looks like hand-picked partnerships that provide the support mothers need to fulfill their family's goals. It feels like a spark when that moment of prayer or spiritual song carries a message from God. It echoes through the wisdom passed on by mothers and grandmothers to help their daughters dream bigger. But just like a cold snap shocks the monarchs, the COVID-19 pandemic devastated migrant mothers. These women lost work and shuttered themselves at home to protect their children. They watched loved ones contract the virus and die. As Jacqueline puts it was like a trauma. I was afraid of what would happen if I got sick. For 3 months, I didn't go out at all. We kept hearing about people dying. Women like Jacqueline need the essentials like food, diapers, and healthcare. They need protection against domestic violence and a clear pathway to citizenship. Policymakers must build a more nurturing home for these migrant women. In New Haven, Connecticut, a longtime refuge for migrants, children build monarch way stations where the butterflies refuel during their long migration. Like the monarchs, we do not have to force migrant women to suffer or starve. We can work together to create a more nourishing and equitable home for our neighbors. So, in this conversation, I have attempted to consolidate hundreds of hours of conversations I had with women, clinicians, community leaders, as well as my own literature research on intergenerational trauma in the Latinx community. And I want to highlight the global and local forces that constrain women's life opportunities and how they push against those to meet their goals. And I'll leave you with a few points. First, intergenerational trauma in the Latinx community transcends parenting behaviors to include the structural vulnerability that constrains those behaviors and accordingly propagates harm across generations. Second, with respect to the migration process, the disintegration of democratic institutions in Latin America breeds mistrust and fear and forces women to migrate, which then entails its own experiences of trauma. Third, despite these harrowing traumas, migration-related trauma may not always register across clinical thresholds on conventional PTSD screening instruments, but may still cause a ruptured sense of self that affects how they engage with the world around them. With that, conventional public and mental health approaches may view few symptoms or the absence of symptoms as evidence of resilience, but I argue instead that this is a necessary conditioned response or resistance to the multiple overlapping oppressions of legal violence, racism, gender-based violence, and economic oppression. Fourth, the term that I use to describe this is imperative resilience, describing the cognitive, social, and emotional strategies migrant Latina mothers use to get by in the day-to-day, to seguir adelante or press onward. Fifth, the COVID-19 pandemic disproportionately impacted racially oppressed groups, particularly Latinx migrants, due to their inability to benefit from social support programs and the extra toll the virus claimed on Latinx bodies. Finally, no woman should be forced to rely on her own intrinsic abilities to survive and build a life for herself and a family in a hostile environment. She deserves to be supported and have enough capacity to grow her self-worth and invest in her dreams. And again, policy reforms like universal health care, basic income and housing support, and pathways to legal migration can make this a reality. So for more on this is my book research. So this is the book Pressing Onward, the Imperative Resilience of Latina Migrant Mothers. And this is a way for you to find it with a discount. And I just wanted to last share a photo of me with the book in front of one of my favorite murals in the neighborhoods where I conducted a lot of my research. So thank you all so much again, and I look forward to your questions and the discussion with Dr. Cardesa.
Thank you so much, Dr. Sarvenia. It's been an honor to hear you. I am going to share my screen. And you can see the main presentation, correct? And not the presenter notes, Dr. Sarvenia?
Yes, we can see it.
Okay, thank you so much. Thank you, Ola. Welcome, everyone. For the way in which I drafted my response, and Dr. Sarvenia, I invite you to stay on camera with us. The way in which I created and crafted my response is that I broke it down into smaller chunks. I will be sharing, lifting Dr. Sarvenia's scholarship in a couple of slides, and then I will pose a question in a following slide, and I hope that format is helpful to you as well. Dr. Sarvenia, in your presentation, we heard about the role of bureaucratic barriers, racialized experiences, and obstetric racism within healthcare systems. You and I both speak Spanish, and in the Latinx community, the way in which we say to give birth, we say dar luz. In English, that translates as to give light. So to give birth for us means to give light. Yet, as I thought about your work with through a Latinx perspective, I held space on the acute trauma that it could mean to give birth, juxtaposed with a compounded layered exposure to experiences and stressors that a Latinx mother carries with her. When we share these stories, we orient and widen the lens of exploration into the lived experiences, and it brings an introspection on how they influence us, both individually and collectively. Thinking about the prenatal care color line and the Latinx migrant motherhood experience, with your research and study, Dr. Sarvenia helps us pull back the veil into the intricate and layered racial dynamics prevalent, not only in the prenatal care system, but in healthcare as well. Emerging from your study is a poignant revelation on the urgent need to address systemic issues intersecting race, bureaucracy, and healthcare access. These insights underscore to me the imperative for collaborative efforts to dismantle the prenatal care color line, health and healing color line, and pave the way toward equitable healthcare provision. Your research uncovers a pervasive medical hierarchy that places white providers and nurses above Black and Brown medical assistants and patients. You listed 3 elements of how these racial hierarchies are manifesting, particularly regarding to enrollment, how Latin American and Latinx mothers face significant barriers to entry, registering and being denied access, racialized, gendered embodiment of the female body, the female identifying body, and racism within healthcare and how it can be denied access or delayed critical medical care while also being subjected to over medicalization during uncomplicated births. Dr. Sardenia, if you could kindly join us in the Zoom. My question to you is, can you discuss lifting your other work on not race competent or cultural competence, but race conscious, community-based initiatives, how they can show promise in supporting Latinx mothers in accessing quality healthcare services?
Thank you for asking about this. And this is something that I think about a lot, particularly regarding the maternal health inequities that we see affecting Black and Latinx birthing people. And this is very salient for the undocumented community as well, because of the way that this disenfranchisement strips away entitlement to benefits that mothers would otherwise receive through the process of seeking healthcare for their children. And as you can see, I am occupying my dual role as also caring for birthing people on this floor and babies. So in answering this question, one initiative that is actually part of my local hospital is called Pregnant with Possibilities. And the focus of this initiative works with people who are pregnant, who are racially oppressed or minoritized in some way, Indigenous, Black, Latinx, and seek to provide wraparound support, including having a person who is informed and involved throughout care visits, and providing a doula. And there's range in kind of the experience and expertise of doula. So I always encourage people who are considering this, but a doula refers to a birth support person who is not necessarily medically or clinically trained, but is able to be a support person and advocate for the birthing parent. And we have seen lots of research come out that shows that when doulas are involved, that labors are shorter. There's less need for interventions and analgesic pain medication, and that we see a major reduction in the adverse outcomes, both associated with the parent and with the baby. And I think thinking about these resources and tailoring them in a way of thinking about racial justice is key, because it would be great to have blanket policies where, and Connecticut is in the process of implementing this, of being able to have patients who receive Medicaid, or Husky, be able to use their payment benefits to allow for a support person or birth support person during delivery. But in the absence of that, having organizations that are specifically targeting the disproportionate impacts that we see of the maternal mortality, infant mortality on Black, Latinx, Indigenous women, focusing on those resources and allocating them appropriately in this kind of race-conscious manner, I think is an important way forward.
Thank you so much. Thank you so much. Speaking of broadening the lens and the aperture, we often see a pixelated picture, an image of what a migrant birthing mother looks like. And so as we widen the lens, addressing systemic issues such as bureaucratic barriers, racialized attitudes, and racism is essential to ensuring equitable, dignified care for Latinx mothers, thereby fostering, I believe, healthier outcomes for both mothers and infants. With that intersection, interconnection, and multiplicity of what that could look like, as I thought about your work, I think about what are those kind of continuing that thread of birthing centers or decolonizing or deconstructing, what does care and access to care look like? I think about what community-based initiatives can be implemented to support Latinx migrant mothers and Latinx community generally in accessing quality healthcare services and healing that promote healing. I want to begin to build the two.
No, thank you. That is a really important and vital question. So I think there are a couple of components of this. So one is thinking about cost and the issue of insurance. So it was actually explicitly stated when the Affordable Care Act was implemented that there would be no protections for undocumented folks. That was a sticking point, and that has remained the case. And this is such that, even through the great healthcare marketplaces that we have, health insurance marketplaces that we have, undocumented folks are cut out. And this is actually a challenge, not just for people who are, with a clear unauthorized status, but even people who experience some liminal legality, where people who are coming here with temporary protective services or here on DACA also have the same kind of barriers encountering healthcare protections and access. So I think on the one hand, there is an insurance issue. I really applaud initiatives that have been done in California. Currently in California, undocumented adults of the age of 26 are able to receive Medi-Cal, which is the state Medicaid. Like I said, I was highlighting some of the activism that I and others have been part of in terms of pushing for the expansion of Husky to include more immigrant children and adults. So I think that is a policy piece. Speaking about kind of more local initiatives, New York City itself, in the absence of the state government, any public hospital where a migrant person who does not necessarily have the ability to apply for state or federal health protections is able to receive free healthcare through the public hospitals. So that is another kind of more local initiative that is key. Now, with that, we also have to think about what kind of services and provisions are included. So beyond just having healthcare coverage, many community initiatives, in my research and the women that I worked with, this was through a privately funded program that was not advertised through the hospital that I was training at. And this was something that, was kind of whispered through word of mouth. But even then, there were limitations on what that care included. Contraception care, not included. Further postpartum care, not included. Any medical kind of complication that was going on, but perhaps not directly related to the pregnancy, you're out of luck. So this really kind of created this condition of like, okay, so we are caring about this future US citizen that is in your gravid abdomen, but you as the parent are kind of stripped away. And I think that we need to abolish that mindset and think about things in terms of children as vulnerable entities that are worthy of policy interventions, but also thinking about parents as people who are experiencing this immense social and structural oppression that deserve this kind of care. So thinking about more wraparound services. And then the last point that I want to make is thinking about how those of us who work in the mental health sphere can consider somebody who, like going back to the narrative of Almudena, is reporting some experiences that are clearly traumatic, some symptoms that are very disruptive in her life, but doesn't cross that threshold where we'd say she's at risk for PTSD and would merit kind of specialized services. We have a lot of power to be able to say, in my clinical judgment, or to be able to say, based on my assessment, I believe this person would benefit from services. And that is where negotiating our own social and cultural capital as people who are here in this conference, have access to various social resources, have our training, fancy degrees behind our names, all of that becomes a huge asset in how we participate and align and advance the goals of the Latinx community.
Thank you, Dr. Saldenia. In my own, you lifted that trauma, multi-generational trauma, identity is both clinical and social. And within that triad, there are, what came up for me was this continuum, this thread of social determinants of health and healing and how they can impact us, as well as policy, legal determinants of healing, and what is the role of the law in accessing and creating pathways to bring about addressing both the clinical and social, individual and collective, the naming and non-naming, and culturally assimilating, acculturating. Do we talk about the past? Do we keep moving forward? And so how do we, in Spanish, it's like vivir and sobrevivir, like how do we live and thrive, right? And so I want to close with thinking about the last question here. There's a lot of advocacy that you're lifting for us in recognizing and addressing trauma. If you can lead us into what does care look like that is equitable, race conscious, that includes belonging. What are your concluding thoughts before we wrap up and open it to questions from the floor?
Absolutely. So I think that for everyone who is kind of considering these concerns and ways to, and I talk about achieving full life potential, because, you know, if you have all of the resources and opportunities and you have not experienced this burden of trauma, you're not encountering, you know, threats of violence, you know, you have so much latitude to be able to pursue your dreams and goals. And that is not the reality of many migrant communities. And I think, you know, they're the different components of the direct, you know, how are we engaging in care and advocacy? You know, I kind of spoke about that feminist care work, you know, of hearing and being present, and then translating, you know, what people's needs are, to be able to connect with direct services. So that's a really key piece. The next part is in terms of advocating for policy reforms. I think that so often we place the burden of agitating for change on the people experiencing that form of oppression or violence. And I think that this is where partnership is key. And thinking about this kind of trauma-informed approach, you know, recognizing that people have experienced this trauma and to relitigate it or to perform it for the sake of having a narrative in front of a legislature or to give testimony is taxing and costly. And that is something where folks working in this sphere can work and unburden people who have experienced this directly in their lives. And this is something that I've done in my own work where, you know, I have reached out to women and said, hey, this initiative is coming before the Board of Alders, or this issue is coming before the state. You know, you shared this with me. Can I share this on your behalf? And had gotten the feedback on, you know, how it was tailored, what was the argument that was made, you know, what to keep in, what to leave out, what details to change for protection. And I think of that as being an entry point and a way in to be able to leverage the positions that we hold, without placing the undue burden of somebody who's already trying to get by in the day-to-day, trying to recover, trying to heal, and then trying to just live to not only vivir, but also to sobrevivir. And what that means for someone. And that is where that kind of partnership, that listening, and that advocacy can be so powerful.
And the humanity of that, and both the compassion and the ecosystem of that. So I am grateful. I thank you so much for your work, for your labor of love, and for shedding light on this experience, and for all of us to be hopeful as well as be mindful and intentional in our attention of others and do care. Thank you, Dr. Sardenia, and thank you to all. I'll stop sharing my screen.
All I can say is wow. Dr. Senyenya and Dr. Cardessa, I am blown away by both of your presentations and the information that you have provided for us today. It was most enlightful and insightful, and I am appreciative, as I am sure those participants who are here today. So I just want to lift up a couple of questions for both of you to answer in whichever order. The first question I have, since we're here talking about intergenerational trauma, we started off the day with the TTP narrative research, and how are you working with the migrant population, the Latinx mothers, and the intergenerational trauma and mitigating, passing down that trauma to the next generation and the next generation? Are you at all dealing with that? And how are you? And how can we, for those of us who work in that community, can also do that?
Thank you so much for that question. So there are multiple things that I think about because this is something that stays on my mind and lives with me as I, see myself as this vessel of all the narratives that women were, so generous in sharing with me. And I see that as kind of my responsibility to kind of make sure that we protect them and their children and their futures. And in terms of thinking about mitigating the impact of that trauma, I think in the first place, there's a need for us to think beyond of what traumatic experience is and means. And I know that I'm preaching to the choir when I say this, but thinking about it beyond these kind of individualized, events of kind of personal violence, thinking about that as, as I describe it, as a clinical and social event. What is the meaning that is made from that experience? How are people constructing trauma narratives? What form of cohesion do they derive from it? So that is one part of the healing process that for anyone who's coming into care, to understand and to think about. I'm seeing in the chat from Dr. Hollander Goldfein about a kind of parenting program talking about sharing experiences. Migration can be so isolating. There are many people who have had the advantage of, coming and being like, the 10th in their family to be part of that migration journey. But for many of these women, they were doing this all by themselves. And to have that kind of affirmation and validation that this is something that is normal and understanding the links between these traumatic events and what they're experiencing, this kind of warlike mistrust or this fear, is so critical. And I also say that with that power of saying not everyone is going to screen at high risk, and when we're trying to think about resource allocation and we tend to triage and we tend to put people with the highest severity, we'll also think, okay, our mental health system is a pyramid. Not everyone needs to be going direct to high acuity intensive treatment, but thinking about what are the role of community health workers, promotores, people who are able to leverage some expertise in a kind of psychoeducation model to be able to kind of promote that sense of empowerment and making sense of what these traumatic histories have been, so that we can hopefully disrupt and prevent the sequelae of these kinds of traumatic experiences.
Thank you so
If I
much.
may
for that.
add to everything that Dr. Sardenia mentioned, there are a couple of things that come up for me in relation to your question. And I think Latinos and the Latinx community are not a monolith. You mentioned this in another panel. We are a mosaic of experiences within Latin American culture, Latinx culture, migrants, immigrants, expats. So it's a layered, intricate mosaic of experiences. Number two, I think that there are the aloneness, the isolation, the longing, birthdays and anniversary dates. So all of these are compounded, right? And so how do we talk about them? In the refugee panel, we heard about assimilating and acculturating. And so if I start talking, we don't look to the past, and how do I navigate? If I explore, so I mentioned in my presentation, exploration and introspection and how they live within our humanity, right? And finally, I'll share, Dr. Sardenia mentioned Latin American violent history. And there's a layer to, in my own experience with political persecution and working with, there's a layer of moral distress. And so what is my experience in relationship to the collective experience of suppression, oppression, and where do I live? So we've been saying living, surviving, and thriving, and there is an accompaniment that happens within those three.
Yeah, Dr. Jones spoke about this dance that one does, right, when navigating in Black and brown spaces, the talks, the conversation, how to navigate this system, which is oppressive to Black and brown people, right? With that said, we know that migration has been politicized for capitalist and racist reasons. And so, how do allies and co conspirators um, join in the fight to decrease their own biases? Right. And I have to admit, there was a time I was biased, right? I was, why are they coming into this country? You know, that whole mantra around migrants. And so could you speak a little bit to how does one become an ally, a co-conspirator when those conversations come up? Uh, Give us some talking points to those who may be uncomfortable or not sure what to say when those conversations come up, especially in the treatment. We're mental behavioral health, right? We're physicians, we're doctors, we're psychologists, we're psychiatrists, we're psychotherapists. So how do we approach that?
This is such a wonderful and important question. And I think that, I try to just touch on it, just the idea of how migration policy is so tailored according to US interests. And, just to give some examples, if we think about the Latin American community, we go back to kind of different points in migration policy where, things were opened up, and we were allowing more people to migrate. But the priorities have always been for people who are well educated, who come from, you know, predominantly white European countries, who are able to supposedly offer a particular skill set, and family reunification. And even within those parameters, there is the subtle and unspoken goal of, we welcome and appreciate you for your labor, but not for respecting you as a whole human person. And, thinking about just the differences between somebody who is coming from, say, Guatemala and somebody who's coming from Cuba. So we know that US policy at a time was saying that, oh gosh, we are very anti-government in Cuba because of its socialist tendencies, coming out of the McCarthyist era in, the mid 20th century, saying that, in the Cold War, thinking about, really tampering on that. And so people who are able to achieve refugee status were aligning with the political vision of the United States and its self-conception. So people who are obtaining refugee status and had all of the attendant legal protections that accompany it, which I recognize are themselves not perfect, but were aligned with the political priorities of the United States at the time. Now compare that with somebody from Guatemala who has experienced the enforcement of the war on drugs, the disintegration of a lot of the legal structures, and basically the transition from the formal government to an informal government that is basically ruled by corruption, gang violence, people who have a lot of economic power from being involved in the drug trade. And a lot of these are effects of US policies, thinking about also US trade agreements that made it much more difficult for a rural Guatemalan farmer to be able to sustain their livelihood when they're competing with large agribusinesses that have now include the whole North and South American continents. So that person, has experienced displacement. If they are an indigenous Mayan, they have perhaps experienced their own genocide based on, racist prerogatives. And yet they would have to come here by bus, on foot, and ultimately transition into the underclass, as I call it, the American underclass of being illegal. Because if you think about it, you can look at the data, and I don't have this to pull up in front of me, but the extent to which asylum is granted to people from Latin America versus people from the African continent, from Asia, and so on, widely varied. And again, that is recognizing that this is a challenging group. And it is also this denial and this white supremacist narrative of the ways that US interventionism has harmed and caused the state failure in many Latin American countries. So I think first, just having that awareness of how policy is political, how yes, it's wonderful that your person, like that somebody like waited 12 years to get their green card and like they did it the right way. Well, it's not possible for everyone to do it the right way. Like there are literally no paths for some people who should have every right to be able to achieve their full potential and protect the futures of their families, and there just is no way. So there is no waiting in line, there is no taking your time, there is no going about it the correct checkboxy method, because there are literally no paths for some people. And the way that there are paths for certain global populations and not others are very much in line with the racist, capitalist, political imperatives of the United States. So I think kind of if we can kind of like unmask ourselves and like realize, like have that like aha, then I think that can promote us to be more empathic and say like, hey, you are just as deserving as this other person, and you in every way deserve all of the kind of resources and attention and ability to kind of dream and enjoy and heal and recover. So that would be what I'd say.
Thank you so much for that insightful response. Anything to add there, Dr. Cardessa?
Only to affirm and support what Dr. Sardenia shared, and that also matters in terms of widening the lens. There is I think these conversations matter. There's competence, there is scholarship that is emerging. And to your earlier point, Anne, curiosity, what is our commonality? Where is our humanity? What do we have in common? I am from the Midwest, I'm from here, I'm from there. Like, how can we find commonality? That's a practical practice tip. While also keeping informed of the role of identity through the lens of our social determinants of health, our compassionate bridge, and then where to from here, and what is the role of legality, identity, and where does that live psychologically, psychosocially? So everything that Dr. Sardenia said, for sure.
Dr. B would like you to talk a little bit about Esperanza.
Sure. Esperanza is a place-based, hope-informed organization that thinks in terms of who am I in the presence of the other, and offers a suite of services, programs that are here in Hunting Park, which is North Philadelphia, which is along the Latino Fifth Street corridor. Lots of amazing cuisine and businesses. And so we have an ecosystem of services and programs, from educational hubs, K-14, Esperanza Academy, Cyber, and the college, all the way to housing, business associations, immigration support. We are driven by hope theory, and hope can be both an imagination of what if, and hope can also be an included grace and believing of a new day, of a new dawn. And so we've been around for about 40 years, and our work in depth is, I go back to being place informed. How is the sidewalk informing the classroom, and vice versa? How does the classroom inform our daily interactions as neighbors and La Comunidad? I hope that's helpful. And I added a lot more in the slides as well. Thank you for asking.
Thank you so much. Thank you so much for your insightful and wonderful conversations in regards to the Latinx, migrant, and female Latina communities. It has been very insightful, and I appreciate you being here. I'm pretty sure that the other presenters, as well as the attendees, have gotten so much from this as much as I have. So again, thank you for the time you spent with us and given to us, and um, what you continue to do, may you continue to do it. We desperately need it. So at this time, we are going to move into our closing reflections. And so, let's see. So what have we attempted to do today? Today we were trying to articulate the impact of trauma, whether it was caused through persecution or racism or discrimination. We looked at the Jewish community, the immigrant community, the migrant community, the refugees, Black and Latinx communities. What I got from this entire day was first that, oh, okay, yes. Can you hear me now? Is that better?
Yes.
Okay,
Yes.
great. You know what? Let me also turn off hold on one second. Had my fan going. All right, so hopefully that's a little bit better. So what we attempted today was to talk about the intergenerational traumas that can be passed down to families and generations, regardless of whether or not it was through persecution, racism, and or discrimination. We looked at it from the lens of the Jewish community. We looked at it from the lens of refugee, migrants, immigrants, the Black and Latinx communities. What I gathered today was that first, what I heard in each presentation throughout the day is that we are all humans. And although we are experiencing very different types of traumas, we are experiencing very similar types of traumas, similar types of oppressions. And at the end of the day, I think that what we must take away from here is that if we worked more collaboratively, if we worked in concert with each other, I believe that more things could be accomplished versus us working in our silos, mistrusting each other based upon the races as well as white supremacy messages that have been put out that create divisions between our groups. It was so uplifting and so enlightening that we all came together to talk about our individual communities and cultures. One of the things that we want to take away today is that narratives matter. B, Jennifer, and Nancy started off talking about TTTP and the importance of the narratives from those who have been impacted by the traumas, regardless of where they come from. In this particular study, they looked at Holocaust survivors, and they looked at how that horrific incident, event, has been carried on and how it impacted even third and fourth generations. But also understanding that if there was a mitigating family member community of how those traumas and traumatic experiences can still come out at the end of the day, and there is a resilience that's bought into. Resilience was talked about a lot today, but I so appreciated what Dr. Cadassa talked about and Dr. Canethius talked about in regards to the resilience and rethinking resilience, and Dr. Jones. They talked about the imperative resistance, and that so resonated with me as an African American woman who comes from the heritage of my ancestors coming here and being enslaved. That resilience that keeps us going, that despite no matter what happens to us, we have to keep moving, and we find a way to make things, as an old adage says, making lemonade out of lemons. And so I so appreciated that pushing forward, Dr. Jones talked about the psychologically defined way of thinking about resilience being the dynamic process which encompasses positive adaptation within the context of a significant adversity. So, psychologically, making the jumps, doing the things that one needs to do, that imperative resistance in order to continue to survive. But I'm hoping that what we can do in the Latinx, the immigrant, the refugee, and the migrant communities is take a page out of the Jewish communities and move to a state of not just surviving, but thriving. Moving to a state where we come together collectively, remembering our past, but forging forward in a way that builds up our future generations so that they can thrive and not continue to survive. The conversation was asked, can we get rid of racism? As a anti-racism consultant, I will tell you that I do not believe so. And that is not from a pessimistic standpoint, but that is from the standpoint that this country was built and has been crafted on the notions of capitalism utilized through the racist and white supremacist tactics to keep us divided. And so instead of trying to necessarily thinking that we can eradicate, we simply work together. And if we work together, one person at a time, one community at a time, what I think can happen is that over time, there will be less and less and less racism that exists. This new generation of Generation Zs and Generation A Alphas, I think they're called, they are really fighting to say that we should work together. So we need to be resistant ecologically. Dr. Jones lifted up the ability for an ecosystem to remain unchanged when being subjected to a disturbance or disturbances. And so we, as a community of oppressed individuals, for our racial complex and makeup, should stand together in solidarity and work with one another so that we can eradicate the impact that racism, that discrimination, as well as oppressive regimes have on our communities individually and collectively. And so we are very excited that we have taken this day. It says amazing day, making gracious to all the yes. And that we have taken this day. And I hope that what we will take away is little tidbits that each person, a presenter, has brought. Dr. Jones mentioned, as we come to the conclusion, as we do this work within ourselves, with others, that we use CLCBE, that we calculate what the toil it is taking on us and make sure that we are using self-care as well as things that continue to infuse positivity within us. I'm always telling my clients, make sure you're dancing, make sure you're laughing, make sure you're connecting with community, kinfolk, as well as those who you are choosing to be family, so that you can mitigate the impact of the oppressive moments that we have in our lives. We need to locate in our bodies where we are feeling it, in the moments that we are feeling it, so that we can do the deep breathing, that we need to communicate to ourselves, communicate to our loved ones, how it is impacting us. We need to breathe and we need to exhale. CLCB is what Dr. Jones provided for us today. At the end of the day, I am so thankful for this opportunity to moderate this day. I hope again that you take away the tidbits and that this will not be the last, but that we will continue to work together and to collaborate in our individual spaces with one another, making sure that we continue to tear down the oppressive systems that currently exist, not only in the United States, but all over the world. I want to thank you for your attention. Thank you for your time. Thank you for your questions, that you stayed and stuck with us. It was a long day, but again, I appreciate all that everyone gave. And so now at this time, I would love to turn it over to Janine for closing remarks. Thank you so much. Have a wonderful rest of the week. Namaste, Ashe, and Amen.
Thank you so much, Anne. Thank you, everyone, for your engagement in this important and timely topic. We had some really profound learnings in today's conference. The importance of cultural humility, trauma-informed care, the burden of racial socialization, anti-racist practice, and imperative resilience, just to name a few. It is now up to each of us to take these learnings back to our communities and continue the discussion and the work to address intergenerational trauma from a cross-cultural perspective. I encourage you to take some time reflecting on how you can change your practice and your advocacy based on what you heard today and what tools you need to do that. I'm so grateful to our presenters and our respondents for all that they brought to us today, for all that they bring to our world, for the hope that they help us to hold out for real change, and to Ann Colley for her excellent moderation for today's conference. Thank you for participating and have a good evening. Take care, everyone.
That concludes our day for today. Again, please make sure that you take away all the tidbits. And again, we hope to see you soon.